catastrophic health expense. Some other people also define it as health expenditure greater than 10% of monthly household income. But either way you define it, patients would experience it. And when they experience catastrophic financial toxicity, they rely on something called distress financing. Now, what is distress financing? It is when patients borrow money or pawn jewelry or use their savings or sell their assets. In India, distress financing is one of the most important mode of payment for hospitalization or, for that matter, outpatient cancer care. It is greater in rural areas than in urban areas. In our study published in Lancet Oncology 2 months ago, we reviewed 22 studies from India systematically and found that around 50% of our patients in India have substantial financial toxicity as measured by prevalence of catastrophic health expenditure. That is, 1 in 2 have catastrophic health expenditure. And that is primarily because the government spending, which is denoted by the blue line, is very low, whereas the out-of-pocket expenditure as a percentage of health expenditure is very high in India. As you can see in the US, the blue line is very high, but that's not very healthy, where the government spending is very high, 20% of the economy. Again, I plead guilty of the fact that I'm not very familiar with the UK scenario, but I'm quite surprised to see that the out-of-pocket expenditure in the UK, as measured in the study, is also not insignificant, despite the fact that there is socialized health care in the UK. So there is no question that cancer care has significant impact on financial status of patients. It happens because of high out-of-pocket spending. It happens because of poor health insurance coverage. It happens because of low public health spending, that is the government spending on healthcare, and greater incidence of advanced cancers, and a paternalistic practice of medicine where doctors sort of decide on behalf of patients what to do, and patients rarely get a chance to discuss their options with doctors because of various compulsions. That, in other words, we call it paternalistic practice of medicine. Sometimes, if used appropriately, it can be a force for good, but that's a whole area of debate otherwise. The conceptual framework of financial toxicity, how does that impact cancer? It can cause objective financial burden, that is loss of income, drug cost, direct medical cost, treatment-related cost. It can result in subjective financial distress, resulting in anxiety, discomfort, loss of income, pawning of savings. So all of this can interplay and cause increasing financial toxicity at any stage of a person's healthcare. And what happens if a patient goes through financial hardship? They cope to it. Now, how do they cope to it? They probably forego a meal a day. They delay care. They may not pursue care that otherwise would probably cure them of their illness. So all these coping behaviors have an impact on their outcomes. And as a result, the financial toxicity of cancer care has substantial consequence on cancer care. It results in poor quality of life, delaying therapy, lack of follow-up, and non-adherence to therapy. And the impact on family is not insignificant. Decreased expenditure on education, entertainment, greater need for doing overtime work, premature entry of youngsters into the labor sector, and in what I usually refer to as accumulation of debts leading to long-term hardship. Patient may pass away, but their family ends up in long-term debt and long-term hardship because of the debt that accumulated because of the treatment of their loved one. Catastrophic expenditure is not just a problem of India alone. It's a problem of primarily low and middle income countries, Africa, South America, parts of Europe, and less often a problem of developed high income countries, partly because of greater expenditure from the government on healthcare, and partly because of greater insurance coverage. As outcomes in cancer have gone up over the last 2 decades or so, for instance, in all cancer, survival outcome has gone from 50% to 70%. In breast cancer, 74% to 90%. So outcomes have improved, but so has the impact on GDP of a country of healthcare. In the US, as you can see, as denoted by the black line, Now it is nearly 20% of the gross domestic product is contributed to by healthcare. The yellow line, the UK is at the bottom among all these developed countries, which is good, not bad. But in terms of cancer care, dramatic increase in spending on drugs, on cancer care has happened in the last 10-15 years and expected to rise. So this is a problem that we don't foresee to stall anytime soon unless we urgently put our attention to this elephant in the room and start talking about it and start doing measures to impact it. So it is a problem that urgently needs a solution, and that solution would mean structural changes and not just patchwork, not just measures to just lay some planks across these bridges that have been misaligned in its construction. And we propose several interventions in our paper for the Lancet Oncology at patient level, provider level, community level, and policy level. Much of what we propose is relevant for the Indian context, but I would like to discuss a few sections that are relevant for a Western setting, some of which are important for countries like US. Again, I plead guilty that I do not for the UK healthcare system. So again, I am open to feedback, to thoughts and comments as I discuss. On a patient level, it is important for the patient to obtain accurate information. It is important that they get a second. Sometimes the first opinion may say, go and get surgery, whereas the second opinion may be more prudent and say, hey, why don't you get a systemic therapy first? See if you can downstage the disease and then pursue surgery if necessary. It's important that patients be forthright about available resources. There's no point hiding the fact that resources are few, which some patients do. Out of fear that I may not give good care, they may say, hey, doc, do everything possible. But at the end of the day, if I do everything possible, they may end up with long-term hardship. So it is important that patients are forthright because I don't know what their resources can be. So they need to be forthright with me. And it is important, especially in settings of advanced cancer, that they discuss and document end-of-life care, advanced care directives. You have to enroll in government schemes, especially if you are hard to survive a poor patient. And at the end of the day, discuss with the doctor. But here's the problem with paternalistic style of practice. Doctors don't have time to discuss, nor are they trained to discuss. So even if a patient wants to discuss, the doctors may not be able to give a proper discussion. So for a Western context, patients may want to ask this question. How much is the cancer treatment going to cost me? Will my health insurance pay for this treatment? Is there any way I can get help to pay for this treatment? To answer a lot of these questions, unfortunately, our doctors may not know the answer to a lot of these questions. So for instance, researchers in Johns Hopkins University asked doctors in that hospital if they were to be shown the cost of a test, will they order fewer tests or more tests or less, same number of tests? They found that in a 6-month baseline period, if the cost of a test is displayed to the doctor as they order the test, the prescriptions on the tests dropped. Whereas if the fees for the test were not displayed during that exact same period, there was an increase in number of prescriptions or tests ordered. So essentially, unfortunately, doctors don't know how much it costs. And because if they don't know how much they cost, if a patient asks the doctor that question, hey doc, how much is my cancer treatment going to cost me? The answer in honesty, well, when I used to practice in the US, if a patient came to me and asked me, hey doctor, how much is my chemotherapy going to cost me? The real answer is, I don't know, because I really don't know. A patient A may have a different bill, patient B may have different bill. In fact, even with the same health insurance, they may pay different. So there is no way I can tell. Will my health insurance pay for this treatment? How much will I have to pay myself? And the answer as a doctor is no, because I don't know. I know this will be expensive. When I get an idea of the total cost of the talked about. And the answer that as a doctor that I have to honestly, I don't know, because I don't know. It's embarrassing, but that's the reality. Now, that's different for an Indian context because of more out-of-pocket spending, less insurance. I know how much what costs. So for all of these questions, if a patient comes to me and asks me, hey, doc, how much is my treatment going to cost me? Will I have to pay myself? Will my health insurance pay for this treatment? What is the total to treatment? I know answers to most or all of these questions. Um, Again, I don't know how this is in the UK context. And that is where I think in the Western context, price transparency is important. And in the US, the Centers for Medical Services have now mandated that hospitals display the price of some tests. Now, how much this has been taken up by hospitals, I'm not sure. And whether it is a law, I'm not sure. But CMS, the Centers for Medical Services, plans to audit a sample of hospitals. So I'm sure we will hear more about how this has changed the practice pattern in various hospitals, maybe in the next few years or so. At a provider level, what can you do? It is important to screen for financial toxicity. It is important to conduct cost discussion during clinical encounter. We need to provide an open communication to patients and caregivers. We have to collaborate with counselors and social workers. And we have to be judicious in the use of diagnostic tests and create resource stratified guidelines. We have to practice evidence-based medicine. We have to avoid low value care and choose wisely. There may be several options in the menu that I can provide. For instance, yesterday a patient's son called me from Denmark and he asked me, hey doc, what are the options for my father who's living in Kerala? And I said there are option 1, 2, 3. 1 would mean a tablet, 2 would mean a tablet plus an IV therapy, 3 would mean a tablet plus an IV plus an IV. Tablet alone, option 1 would be the cheapest, option 2 would be better than that, option 3 would be slightly better than that. But option 3 is dramatically more expensive than option 2 or option 1. Just because you would think that option 3 is dramatically more expensive than option 2 or option 1, please understand that the benefit is not dramatically any better. The benefit for that drug that is very expensive is marginal. So that kind of a discussion helps patients and the relatives to understand the value of therapy. So I have to choose wisely from these options, and I can't just go by protocol. A normal protocol in a Western country would say option 3, but I can't practice that here in India because I would leave my patient at risk for substantial financial toxicity. Now, you may wonder, what am I talking about? I'm talking about option 1 being capecitabine, that is a tablet given for colon cancer. Option 2 is capecitabine plus oxaliplatin combination. 3 is capecitabine plus oxaliplatin plus bevacizumab, which is a monoclonal antibody, and that is very expensive. But the benefit of bevacizumab is marginal. So that is a sort of discussion I need to have with my patients, and that is a sort of choosing wisely that I need to adopt when I practice here or there. But in Western countries, because of protocols, because of unawareness of the financial toxicity issue, as a doctor, I used to not even have such a discussion with my patient. I used to practice in the US. I would automatically go for option 3. That was my standard thing to do. At a provider level, I need to ensure quality surgical care, use radiation treatment protocols that are appropriate. I must be judicious in using 3D conformal therapy or proton therapy, where a simple, straightforward therapy radiation protocol would suffice. Early palliative care for patients with incurable cancer may help, and I have to advocate for cost-sensitive policy making. As a doctor, it is my responsibility to advocate. Now, as an example for high-income countries, screening for financial toxicity, there are various questionnaires that you can use. Conducting in this study, 3 questions were being asked. At any time in the past 3 months, have you taken less medication than was prescribed because of the cost? Second question, when you think about the amount of income that you have in a typical month, is there enough for your food and housing costs? And third question, when you think about the amount of income that you have available in a typical month, is it enough for things you really need like clothing, medicine, repairs to the home, or transportation? So answer yes to any of these questions. That would be characterized as criteria for financial toxicity. And in this study, among patients, older patients with advanced cancer, financial toxicity was reported by 1/5 of patients in the US. And those who had financial toxicity had substantially more depression, anxiety, and lower health related quality of life. But this is what I wanted to point out. Uh, Only 50% of patients had a conversation with their doctors about cost of care. So again, when I talk about conducting cost discussion during clinical encounters, very few of our healthcare providers are doing such a cost discussion during clinical encounters, as can be seen by the study. Well, I can admit that in my experience as a doctor practicing in the US, the number of times I've had a substantial, important cost discussion with a patient coming to see me is probably under 5%. And that could be because of my ignorance. That could be because of lack of confidence for my ability to have such a discussion in an American context. But that's the truth, and that needs to change. Another thing that we need to be aware in a high income setting is judicious use of diagnostic tests. When I was a resident rounding in my clinical service, I used to order CBC, RFT, that's renal function test, complete blood count, liver function test for almost all patients on a regular basis. I never even thought about the cost it incurred on the patients. But now, as a doctor practicing in India, I'm very judicious. Even testing a sodium can cost some money. Testing a potassium can cost some money. So I'm very judicious when I order diagnostic tests. Now, I regret the fact that I was not judicious when I used to practice in the US. I may have just ordered it out of practice, out of doing it on a daily routine. But this is something that we need to train our doctors, because it is widely acknowledged that we waste billions and billions of dollars doing unnecessary testing. So that is where Choosing Wisely campaign talks about how to do testing in a wise manner. For instance, doing surveillance testing, PET CTs. How often should you do it? Or should you even do it? And such measures are being advocated in such campaigns called Choosing Wisely campaign. These are brought out in the form of journal articles, but their uptake in communities is questionable. So there is always a disparity between what is published and what is actually being practiced. And I think if somebody studies the actual uptake of Choosing Wisely at a community level, we may find that there is substantial difference. Or for that matter, even test community doctors whether they are aware of Choosing Wisely campaign points. You may find dramatically conflicting or contradicting reports. Some of these high value therapy that are top earning drugs for some big pharma companies are drugs with marginal benefit. So we have to be very careful with picking drugs, choose wisely for our patients. Again, early palliative care is important. Early palliative care for patients who have advanced cancer improves quality of life, thereby saving patients being on the ventilator and accumulate expenditure. Just today, my patient's son came all the way from the Middle East to see his mother. His mother is on BiPAP, a non-invasive ventilation. So I told the son, your mother is not going to do well. I don't think putting her on a ventilator is a good option. He was in tears. He pleaded with me to put her on the ventilator and explore all options. I said that it's 100% certain that there is nothing I can do. Her condition cannot be reversed if she is on a ventilator. It took me half an hour of face-to-face conversation and another half an hour of phone call and answering his questions patiently through some moments of sobbing and tears. Finally, he left me a voice message around a few hours earlier that said, please don't put my mother on a ventilator if she deteriorates. So early palliative care is important. Discussing such measures is important because our patients, we know for a matter of fact, will not do well if they have end-stage cancer and are in terminally and critically ill conditions in the ICU. So putting them on in the ventilator may be an easy answer to a long, prolonged discussion. For instance, I did not have to talk to an hour to my patient's son about this question. The easy option for me was to put her on the ventilator if her condition deteriorates, and then have a discussion at a later stage, maybe 2 or 3 days later, or maybe 5 days later. but it took away 1 hour of my time, and that 1 hour of my time is not compensated. So what is the incentive for me to have a discussion with my patients, family members, on topics of themes of vital importance such as palliative care? That how do we reward the doctors? How do we incentivize the healthcare providers for such discussions that are meaningful and that are important? That is again unknown. So again, early end of life discussion is associated with less aggressive care and greater use of hospice at end of life care. Now, as a doctor, I need to advocate for better cost sensitive policy making. For instance, when a drug called aflibercept was in the US, doctors in a big hospital called Memorial Sloan Kettering Cancer Center decided not to purchase it. And just doing that immediately dropped the cost of drug by half. So NICE does that in a very amazing way. That's your NHS quality organization. And when NICE evaluates drugs, for instance, a drug called trastuzumab emtansine, and negotiated with the company and said that the cost that you are giving it to us is not meaningful enough to be widely used in our health system, negotiated hard, and the company had to drop the price to, I'm not sure how much, by how much. I think that's under close confidential documents. But essentially, having an organization like that, having substantial advocacy bodies like doctors coming together and saying that we won't prescribe this drug unless you bring the cost down, will not actually, we have to do such measures in today's environment to help our patients and advocate for sensitive policy making and drug pricing. So the oncologist is a gatekeeper to mitigate financial toxicity. A lot of these points that I talked about, at the end of the day, it is the responsibility of an oncologist to be an effective gatekeeper before it impacts a patient. At a community level, there's a lot of things that patients and societies can do. Philanthropic support, greater awareness on cancer prevention, screening and early diagnosis, cost-sensitive lodging. Patients travel from far and away to get treatment in cities. So can we provide them cost-sensitive lodging facilities? And there's a lot of unconventional alternative medicine clinics that sell cure snake oil, but they charge huge amounts of money. Patients end up being cheated, but they don't know about it. So how do we discourage such fake doctors or fake products, or the people who sell snake oil to susceptible, gullible patients and their family members? How do we use judicious social media to disseminate cancer-related information? We have seen how much of an impact, almost negatively, social media has on policy making, on politics, and on war, as you can see in the current war that is going on in the north of the world. I don't even know to call it Europe or Asia. That is why I had to choose my word, whether to call it part of Europe or Asia. Anyway, I'm sure everybody has that dilemma at the moment. Provide patient navigation and call center service for early diagnosis and appropriate referral. Recently, I started a call center service for early diagnosis of breast cancer. And in the first week of having that call center service, all I said is we will have 5 nurses who will be answering calls. If patients have symptoms of early breast cancer, please call. Our nurses would be effective guidance counselors or motivators. We had 210 calls in the first week. Bulk of that call was asking whether they could get free treatment, which we were not able to provide, which we will not be able to provide. And the intention of the call center was not to give free treatment, but the intention was to motivate women to seek early diagnosis if they felt a lump, and make sure that they don't present with neglected cancers. About 1/5 of the call were women who had some symptom, and some of them needed that motivation to go see a doctor nearby. They didn't have to come to see me. They were just guided to a facility near their house. So can a call center service help in early diagnosis of breast cancer? I'm testing it out in a non-research setting in my community right now. It's a breast cancer early diagnosis call center. So these are some of the community level interventions that we can do. At a policy level, we need to encourage the government to spend more in the public healthcare sector. We need to increase the enrollment of eligible persons in government schemes. We need to improve cost discussion training in our training programs. Regulation of drugs should be important, and we need to encourage high quality generic and biosimilar drug research and support indigenous research programs for novel drug development and technology. We need to encourage clinical cancer research in high burden conditions, sensible reimbursement policy in insurance scheme. Because some of the patients who have insurance who come to me, they won't be reimbursed for daycare therapy. They have to be admitted, and the cost of admission for the room rent, for the nursing care, for 3 days stay is much more than what would cost if they had just come for daycare therapy. So sometimes it is mind blowing that companies don't think about the cost saving that they can approve daycare therapy. So that's why I call it sensible reimbursement policy. We need to incorporate health technology assessment programs. We need to provide discounted lodging and travel, preventive strategies, screening, anti-tobacco measures, lifestyle modifications should be important, should be encouraged, should be incentivized. And there is a scope, there is a need for good quality population-based cancer registries. Now, I'm not going to go too much into this part, policy level, but there's a lot that can be done in terms of training, in terms of drug regulation. In terms of drug regulation, let me talk about value-based medicine. Now, what is the value of a drug, value of an intervention? It is the perceived benefit that you can get, survival benefit, upon the cost that you spend. For instance, Adam Smith in The Welfare of Nations talk about the diamond water paradox. You can live without a diamond, but you can't live without water. But water is cheap, diamond is pricey. Well, there is a point, but the point is diamond has a high cost. So, but the value of water is invaluable. So it works with price is what you pay and value is what you get. And as healthcare providers, as scientists, as researchers, as advocates for good policy making, we should always advocate for value-based healthcare benefits. And there are measures that you can do to check for value. The European Society of Medical Oncology have created a scale where in the early cancer setting, you can categorize drugs based on value as A, B, C. If you categorize drug in A or B, that is substantial benefit. In the advanced cancer setting, you can categorize drugs on a scale of 1 to 5. If a drug falls in 5 or 4, they have substantial benefit. Let me explain. Pertuzumab is a high value, high price drug. In the early breast cancer setting, the value is C. As you can see, C in the early setting means in not substantial benefit. It lacks substantial benefit. So in the early stage setting for breast cancer, pertuzumab is not a valuable drug. Whereas in the advanced setting, the score is 4. Over here, 5 and 4 means substantial benefit. So the advanced setting, pertuzumab seems to be a valuable drug. So even for a single drug in different setting, the value of that drug may differ. And that's where I have been proposing, or I am even can be fine-tuned on the basis of indications, on the basis of the value that they provide, and not just an outrightly a maximum retail pricing on a drug package, regardless of what indication you use it for. There are other scales that people can use, sometimes called the ASCO, the American Society of Clinical Oncology. This is just to show that a lot of the newer medicines that are introduced currently lack substantial value. Important that we actually provide good value for our therapy. Now, I'm just going to move over on some of these topics because I've been talking about this already. It is important that societies and governments have negotiating power. Look at the expense of drugs in the US versus Norway, or for that matter, is Norway with UK. The price of drugs in US is much high because health systems are unable to negotiate with pharma companies by law, whereas institutions like NICE allows for negotiation with pharma companies, and therefore you can bring down the cost of therapy. So negotiating power must be used. And high quality generic products and biosimilars should be used. For instance, trastuzumab is a monoclonal antibody, when biosimilar drugs that are drugs that were found to be equivalent in its efficacy based on pharmacokinetic studies were introduced into the market, it resulted in substantial reduction in cost burden. As a practicing doctor in India, I know how important generics and biosimilars can be in reducing the cost of therapy. So developed countries have been a little hesitant to using generics and biosimilars out of fear that the quality is bad or poor. But there are ways you can always check for good quality. And I think using the measures that you can adopt to check for good quality, which can be as simple as frequent drug inspections, random checking, and a lot of other things that I'm not technically competent to talk about, we can improve the quality of generics and biosimilars. Again, I do accept and admit that the quality is not perfect in India. There are wide disparity in the quality of generics and biosimilars that we get. There is still miles to go before we improve on our drug quality. But there's no two ways about the fact that having a widely available generic and biosimilar program have substantially reduced the cost of therapy. For instance, trastuzumab costs one third. Biosimilar of trastuzumab costs one third currently from when compared to the innovator drug at the moment in India. Uh, Pharmacoeconomics is another field where dosing modification strategy, for instance, reducing the dose of drug based on how you administer the drug with food or without food, or how do you administer the drug with some other medicines, the drug interactions, the way different weight-based dosing strategies could function. A lot of ways to reduce cost of drug by reducing the dosing. So not just reducing the cost of drug by asking pharma companies to reduce the cost or negotiating, but essentially without losing efficacy or effectiveness, can we reduce the dose of drugs? And I have successfully used this in my practice based on some PK studies published in literature. And some of the common strategies that I and a lot of my colleagues use that in India are centering around abiraterone. The standard dose is 1,000 milligrams in a fasting state, milligrams with food. Uh, it is research suggests that PK studies, pharmacokinetic studies, and suggest that I would get almost similar blood measures as blood drug levels as I would get with the 1,000 milligram dosing. Lapatinib is another drug that I can dose with food and therefore reduce the cost of drug prescription. So reducing from 1,000 milligrams to 250 milligrams immediately reduces the cost of abiraterone by 1/4, sorry, by 3/4. Again, another molecule that I sometimes play around with is pembrolizumab. The flat dose is 200 milligrams, but we know from studies that 2 milligrams per kilogram body dose is appropriate, or even 1 milligram per kilogram body weight is appropriate. So for a 60 kilogram patient, 120 milligrams should be sufficient. So sometimes I don't give the 200 milligram flat dose. Instead, I would just give the lower weight based dose. In fact, we can adjust using half-life as well. Some of these drugs are administered currently at 3-week interval or 2-week interval, but the studies show that the half-life is actually longer than that. It's probably 4 weeks or 6 weeks. So some of these drugs I have, in fact, reduced the dosing interval from 3-weekly to 4-weekly. So for instance, the drug called atezolizumab, which is an immunotherapy by a company called Roche, I have reduced the dosing interval from 3-weekly to 4-weekly. Thereby, the cost of drug for a year drops from 12 infusions to for 17 infusions to 12 infusions. So I save 5 infusions cost a year. So there are various ways you can reduce the cost of drug by playing around with pharmacoeconomics. And I believe there is going to be greater attention, as you can see from this New England Journal editorial a few months ago from FDA's Rick Pasteur and his colleagues, about how they are now requesting or demanding clinical trialists to provide data on alternating drug dosing strategies when they introduce novel therapy, even in registration trials. So it is now becoming more widely acceptable that pharmacoeconomic strategies can be pursued to reduce the cost of drugs, to reduce the cost of cancer care. To conclude, we now understand that financial toxicity is relevant. We know that the consequences to cancer care's financial toxicity is at various levels, and that it impacts cancer-related outcomes and can wreck a family's catastrophic health expenditure. There are steps we can take to mitigate the impact of financial toxicity at various levels, as I just discussed. And slowly and steadily, I believe we can make this world a better place by working, by attacking at some parts of this in our own regular ways as much as we can do. My good friend and colleague Ankuraj, for instance, is doing his bit by developing tests or research strategies that can help identify biomarkers that can then be used to provide certain drugs to patients who absolutely need it, rather than providing to everybody. So all of the drugs, all of the studies that my colleagues across in the UK are doing are relevant for our practice as an oncologist here in India and across the world. So from the bottom of my heart, thank you for this opportunity and thank you for doing what you're doing. I will conclude my talk now, and I'm happy to listen to you and listen to your thoughts on this presentation, as well as your thoughts on some of the questions that I raised about the practice in the UK. If I was very fast, I apologize. My intention was to complete it so that I can spend time to talk to you. That was the plan. Thank you.
Thanks, Saju. That's really amazing presentation. I think it was clear as far as I can say, and it was a clear message to the community. So sorry for my voice. I think you have summarized. I mean, you not only provided the financial toxicity exists in, for example, in India, but also provided how you really mitigate this, which is like, for researchers like myself, which provides some opportunity to learn, and how one way or the other we could potentially take the opportunity to help clinicians like yourself. So this is great. I have, please post your questions so we can ask Aju. So there's a few questions from Karishma. As for the level, I'm sorry, as far as the level of providers, I would like to add that one should be more careful about introducing expensive medical innovations on a large scale. One of the main causes of rising cost is the introduction of medical innovations, and once implemented or used, it often cannot be implemented. It's more of a comment plus.
Yeah, but at the same time, at the same time, medical innovations are vital, are important, and medical innovations are what have improved outcomes. So I am all for medical innovations, but we need to use checks and balances to make sure the medical innovations are being translated to the clinic in a judicious way. For instance, use of immunotherapy. It's a dramatic innovation to the extent that the founders or the proponents of immunotherapy were even awarded the Nobel Prize for medicine. So there's no two ways about it. But how can we judiciously translate that in the clinic? That's up to policymakers, doctors like me, like all of us, researchers like all of you have to think about. So checks and balances, I always encourage innovations, but I think we need to be gatekeepers of innovations.
Yeah. So there's another question from her again. Good recommendations. At policy level, I would strongly recommend being stricter in the evaluation of medical innovations. Is related question. To be more specific, to make early economic assessment mandatory, and to implement innovations in a few centers instead of wide scale.
Yeah, economic assessment is important. Making it mandatory can be part of the policy making. Good thought. And I think that is where NICE is important. Institutions like NICE. India just set in place a National Health Technology Assessment Policy Group. I don't know how important that would be, how conflicted it may end up being. I don't know. But your point about implementing innovations in a few centers instead of wider scale is challenging, because why would a patient living far away from one of that few centers, why would that patient be deprived of a life-saving therapy? Such questions that matter to ethics of practice may come up. So again, I don't know the answer to that, but that is a bioethics question. Can we restrict innovations to few centers, then what would people who live far away from those areas? I don't know. But one way I know US does it, US Veterans Administration does it, is, for instance, stem cell transplantation. They pool it in few cities. So if I used to practice in the Veterans Hospital in Pittsburgh, I have a patient who needs the stem cell transplantation. The VA system, that's the Army Veterans Health System, they would fund the patient's travel and lodging to go to a city, for instance, San Antonio in Texas, to get that stem cell transplant there. Instead of, so they would work on volumes to achieve quality, and they would compensate. So can that be an answer to the thing that you're proposing? I don't know.
Okay, that's great. So there's another question from Catherine Huntley. I was interested to hear your thoughts on the costs to the clinician of discussing costs of treatment with their patients. How can we reimburse clinicians for this? Or does the true responsibility lie higher up with policymakers?
Well, I don't know. Again, the US, for instance, have made some movement in this regard. Some of the palliative care discussions are provided, end of life discussions are provided fee for service. So they have made some changes in their insurance and their Medicaid policies. Another way the US system does it is you can bill according to the time you spend. So as a doctor, I can spend a lot of time with my patient. The way I get paid for my services is based on complexity of care I give. So this is one way doctors and health systems actually screw the system, if I may use that word. I would just see a patient for 5 minutes, but my note would be this long. It would have all sorts of problems, patient's history of hip replacement, and that's irrelevant for the cancer field, okay? So I would say, under diagnosis, I would say stage 4 lung cancer, on chemotherapy, history of diabetes, history of hypertension, cataract surgery, glaucoma surgery, fall 10, 20 years ago. So these would all be listed as diagnosis. So the billers and coders, when they see it directly, they would say, oh, this is a very complex infraction. Let's bill it at level 5. Whereas, you can essentially game the system by writing big notes so that the billers and coders can actually, they would feel that this is a very complex discussion that has undergone. Whereas a doctor who's very naive or very sincere would probably just say, diagnosis stage 4 lung cancer. I've given a chemotherapy this and this dose today. It'll be such a small note, but a vital interaction. But the billers and coders would see that and say, oh, it's a small note, so it's not a very complex decision making. The level 1 visit, okay? So this is how you can game the system. But in the US, you can essentially bill based on time spent with the patient. So I just need to introduce this clause in my medical note that say, I spend 60 minutes with my patient, out of which more than 50% of the time I spend in discussing options of therapy and answering their questions. And just having that statement, my complexity of visit would be at a higher level. In India, I don't know how to answer this, how to solve this puzzle. But again, such systems can be gamed as well.
That's great. Please post your questions. So I have a few questions. One is, I mean, obviously, as somebody who develops biomarker and diagnostic. So you mentioned about bevacizumab in colorectal cancer, which I also work on. How many patients actually have access to cetuximab or any of those expensive drugs? First question. The second one,
yeah.
How does it work with the KRAS test? Is that like everyone get access to the KRAS test like here to determine if cetuximab would be beneficial for those patients, for example?
Yeah. So the company that provides cetuximab gives free KRAS testing because they want that testing to be done so that we can then provide, the company gets more patients to be considered to be given the drug. In my last 2.5 years or two and a half years of practice in India, the number of patients I've given cetuximab is 0. It's unaffordable. And why is that so? there are no biosimilars. In fact, a company just told me that a few days ago that they are going to introduce a biosimilar soon for cetuximab. Now, how much would the cost be dropped? I don't know, but I expect that the cost would be dropped by 3/4, maybe to 1/4 of the current pricing. So again, cost of care issues, generic versus biosimilar versus innovator problems. So all of these testing are widely used. I don't order tests that I don't think will impact my care. So if I know that the patient can't afford cetuximab, I don't order KRAS testing.
And that leads to next question. Okay, it's great. Biosimilars are coming up. Obviously, trastuzumab is one example, but I don't know if by numbers if really it's making sense to my head. I mean, my sense is that 21% reduction is what you said with biosimilar in your data.
That's a
Yeah.
Ankush, that's a US number. In the US, only 21% reduction because they are negotiating. The biosimilar companies are negotiating well when they get to the US. They are smart. In India, the cost drops by 75%.
Okay,
So
that's what I want.
trastuzumab, yeah, because
No,
you have more
I
options.
misunderstood that it was probably in India. So okay, that makes sense.
Yeah.
Yeah. So that takes me to another question related to the cetuximab is that that means like certain patients who are eligible for cetuximab probably because of the cost issues they are being they cannot take it or they're neglected from taking this. So this means like from what you're saying, if it's 0%, so that means for example here 35% of the patients are responding in the metastatic setting. So that entire 30% population are neglected from getting the cetuximab. That's a huge number. So they are denied to get treatment because, okay, okay. Well, that's
Let me talk to you about another example. Today, my nurse, one of my nurses who works in the emergency room, she came to me with her mother. Well, came to me last week with her mother-in-law, and they have ERPR negative breast cancer, HER2 2+ by IEC. When the HER2 is 2+, I should order a HER2 FISH test. And if they order the FISH test and it comes back positive, I need to purchase trastuzumab for this patient who has stage 4 disease. They just told me that their father-in-law passed away with COVID. They are bankrupt. What did I do? I didn't even order her to FISH testing. I'm not even planning to give her trastuzumab. And even the dose-dense doxorubicin and cyclophosphamide, I just treated her yesterday, free of cost. I got the medicines from a drug stockist. I told them I need medicine because I've been ordering from the company. They know that I've been using for other patients. So, here you can negotiate. So sometimes I negotiate with trastuzumab biosimilar companies. Hey, I'm taking 5 vials from you. I need 1 free. If not, I'm going to the other company. The other company has promised me 5 buy 5 get 1 free. If you don't give me that, I'm going to another. So there are ways I can play, but that's not an ideal system. It stresses me out. I'm all gray now in my head. So as a doctor, it stresses me out. I'm a gatekeeper, but it stresses me out. I have to make decisions, paternalistic decisions on patients' behalf.
And that takes me to interesting. So you showed some data about Norway versus US and the drug costs, and then absolutely from NICE and NHS point of view, there would be a substantial reduction in the cost, I guess. So the similar kind of arrangement is happening in India, who negotiates to reduce the cost with the pharma companies. How does it work? Is there something like that happening?
In the US?
No, in India.
No, nothing. Negotiations with the pharma companies? No, nothing. I mean, I can negotiate this way. I can say that I can put one.
No, I'm not talking
against the other and say,
but if it's a
policy.
bodies, yeah.
Oh, okay. The NICE. No, not yet. Not yet. For that, you need to have the government spend money, right? The government is the biggest purchaser of drugs. But at individual hospital levels, that is happening. For instance, the Tata Medical Center, they purchase tremendous numbers of vials of trastuzumab every year. So they can issue a tender for purchasing trastuzumab, and drug companies can bid for that, and they would then bid for the lowest, right? But individual doctors like me who don't buy big numbers of drugs can't have access to that kind of negotiating capacity. So there are ways to go around it. There are some initiatives being pursued currently where doctors like me can pool in with other doctors and use this negotiating capacity to procure drugs. But we are at least several years away from that possibility.
So probably this is the last question. There are some other things, but you mentioned about the atozolizumab, which you're using, and it was like retracted by by Roche in the US, right? Recently. So, but I saw a couple of days or weeks time that actually it was still approved in India for quite a while, but just recently it was also withdrawn, right? That means like, is it still approved, or it's still working in India? I don't
Well,
know.
it is not approved for that. It is not approved for that indication, but there are ways to get around the system too. I can write for some other indication and get the drug. Um, but so that is where the gatekeepers are going to be important. So I don't think that drug approval matters much or the drug revocation matters much as long as doctors are understand, what is for what medicine is for what indication. Um, but more importantly is demanding good data before drug approval happens.
Great. And Ajay, actually, this is really very exciting topic, and we can talk forever. However, I mean, it's 1 hour has gone already. So, I would like to thank you for your time and giving this wonderful talk. And also to thank the audience for their patience and interacting with Ajay. If you need to contact him, I think please contact me. I can give his email, or you can Google. Probably find this.
It's I'll just drop it here.
Yeah, right.
But feel free to mail me your thoughts on whatever you heard today. And thank you for the attention. Thank you for patiently listening. And thank you, Ankuraj, for the platform. I appreciate it.
Definitely. All right. Thank you, everyone. And see you in the next Center for Global Oncology. And have a nice day.